What if the reading your doctor waved off as fine is quietly wearing down your arteries? And what if the reading that made them reach for a prescription pad was actually normal for someone your age? I know that sounds contradictory. But after more than 2 decades treating blood pressure in patients over 60, I can tell you the most dangerous thing about blood pressure isn't the number itself. It's that most people, and honestly, a fair number of doctors, are reading it wrong. Here's a statistic that should get your attention. Roughly half of American adults have high blood pressure. Past 60, that figure climbs above 70%. 7 out of 10 people your age are walking around with a reading classified as elevated or high. But here's the part almost nobody explains. Cardiovascular risk doesn't switch on at some magic cutoff. It climbs slowly and continuously, starting well below the point most people think of as dangerous. So the real question isn't just, is my blood pressure too high? It's too high for whom, under what conditions, and measured against what baseline? That's what this video answers. I'm Dr. John Myers, an internal medicine physician who has spent the bulk of my career focused on blood pressure in older adults. I've sat with patients who were terrified because one doctor told them their numbers were dangerous and another told them they were fine. I've seen people over-medicated to the point of dizziness, and others under-medicated and drifting toward a stroke without any idea it was coming. None of that confusion is the patient's fault. The guidelines have shifted more than once. Numbers considered safe 20 years ago are now considered risky, and most home readings are far less reliable than people assume. Today, I'll walk through what actually counts as too high after 60, based on the largest blood pressure trials ever run, including the SPRINT trial that reshaped treatment for older adults. I'll show you a number almost no doctor ever mentions, one you can calculate in 5 seconds, that predicts heart attack and stroke risk better than either the top or bottom number alone. And I'll point out the measurement mistakes that are quietly giving millions of people false readings in both directions. Quick note before we go further. This channel is new, and a quick subscribe genuinely helps more people find this. And if you want the fuller picture, the same guidance I give patients on blood pressure, blood sugar, memory, and balance. It's at dorajohnmyers.com, linked below. Let's start with the basics most people never had explained properly, because until this part clicks, nothing else will make sense. A blood pressure reading has 2 numbers, and most people only pay attention to one. The top number, systolic pressure, is the force of blood against your artery walls the moment your heart contracts. Think of a wave slamming into a seawall. The bottom number, diastolic pressure, is the pressure that remains between heartbeats when the heart is relaxed. Think of the tide level once the wave has receded. Both numbers matter, but after 60 they don't matter equally, and the reason is worth understanding. As arteries age, they stiffen and lose elasticity. A stiffer artery can't absorb the force of each heartbeat the way a flexible one can, so the systolic number tends to climb with age. Not necessarily from disease, but from the simple mechanics of aging blood vessels. Meanwhile, stiff arteries recoil less between beats, so diastolic pressure often holds steady or even drops. The result is a pattern extremely common after 60 called isolated systolic hypertension, a high top number paired with a normal or low bottom number. This is where a lot of outdated thinking causes real harm. For years, physicians were taught that a normal systolic reading was roughly 100 plus your age, meaning a 70-year-old with a reading of 170 was considered fine. We now know that's false. Clinical trial data shows sustained systolic pressure around 170 in a 70-year-old meaningfully raises the risk of stroke, heart failure, kidney damage, and cognitive decline. That old rule gave people false reassurance while damage accumulated quietly. but the correction swung too far the other way. In 2017, guidelines lowered the threshold for high blood pressure to 130/80, and overnight millions of previously normal older adults were reclassified as hypertensive worse, many of whom felt perfectly well and ended up on medication they may not have needed. So what's the real answer? The most rigorous evidence comes from the SPRINT trial, published in the New England Journal of Medicine in 2015. Over 9,300 participants, the largest blood pressure treatment trial ever conducted. It found that targeting a systolic pressure below 120 cut heart attacks, strokes, and cardiovascular deaths by roughly 25%, compared with the older target of below 140. In adults over 75, the benefit was even larger, about a 33% reduction in cardiovascular events. But, and this matters, aggressive treatment carried real costs: more fainting, more electrolyte problems, more kidney strain, more falls. In older adults, a fall caused by overtreatment can be just as dangerous as the blood pressure itself. So there's no single number that's too high for everyone. The right target depends on your age, overall health, risk factors, and history. Here's how the research breaks it down. For adults 60 to 75, below 130 systolic at rest is ideal. 130, 139 is acceptable if you feel well. 140, 149 warrants monitoring and lifestyle changes, and 150 or higher, sustained at rest, needs action. For adults over 75, below 140 is the general goal. 140, 149 depends on how you feel and your fall risk, and 150 or above, sustained, is too high, regardless of age. For diastolic pressure, below 80 is ideal. 80, 89 is worth watching, and 90 or above, sustained, puts real strain on your arteries and organs. Now, the hidden number I mentioned, one you can calculate from any reading in about 5 seconds, and one that research shows predicts cardiovascular risk more accurately than either number alone, especially past 60. It's called pulse pressure, simply the gap between your top and bottom numbers. A reading of 150/70 gives a pulse pressure of 80. A reading of 130/80 gives a pulse pressure of 50. Why does the gap matter so much? Because pulse pressure is essentially a direct readout of arterial stiffness. Stiffer arteries push the top number up and let the bottom number drift down, widening the gap. And that widening gap is one of the clearest cardiovascular warning signs in older adults. Research using Framingham Heart Study data found pulse pressure predicted cardiovascular events more reliably than systolic or diastolic pressure, taken alone in adults over 60. As a rough guide, below 40 is normal. 40, 60 is worth monitoring, and above 60 signals meaningful arterial stiffness and elevated risk. So if your reading is 160/70, most people fixate on the 160 bonder, but the pulse pressure is 90, and that's the bigger alarm bell. There's a flip side almost nobody discusses. A diastolic number that's too low can be just as dangerous as one that's too high. In older adults, a diastolic reading consistently below 60 is a genuine concern, because it means the pressure feeding the heart muscle between beats may not be adequate. I once cared for a retired mechanic in his mid-70s who was on 3 blood pressure medications. His systolic was well controlled around 128 to Bart, but his diastolic had drifted down to 52. He was dizzy every time he stood, and had fallen twice in a month. He wasn't heading toward a stroke. He was over-medicated. Once we carefully reduced one medication, his diastolic rose to the high 60s within weeks. The dizziness stopped, and his blood pressure stayed controlled. His prior care had focused entirely on the top number, and nobody had noticed the bottom had dropped too far. Don't just watch one number. Calculate the gap and make sure your diastolic hasn't slipped below 60. Take a second right now and ask yourself, do you actually know your blood pressure? Not from your last checkup, but recently. Have you ever calculated your own pulse pressure? Drop your numbers in the comments. I read them. Next, let's talk about why so many readings are wrong in the first place. Because these mistakes alone can shift a reading by 20 or 30 points, turning a normal number into an alarming one. Or the reverse. Mistake 1. Measuring without resting first. Walking in, checking in, sitting down, and getting measured within a minute of arriving typically inflates systolic pressure by 10 to 15 points compared with a reading taken after 5 minutes of quiet rest. Mistake 2. Talking during the measurement, which research shows can raise systolic pressure by a similar 10 to 15 points. A casual question from the nurse and an answer from you is enough to shift the number. Mistake 3. Crossing your legs, which alone can add 5 to 8 points. Stack all 3 together, and you can be measuring 25 to 35 points above your true resting pressure, enough to change a diagnosis entirely. Mistake 4. Using the wrong arm or an ill-fitting cuff. Readings commonly differ by 5 to 10 points between arms, and a cuff that's too small for your arm will inflate the number artificially, something rarely checked. Mistake 5. White coat hypertension, where the anxiety of a clinical setting spikes your pressure without you consciously feeling anxious at all. Studies suggest this affects roughly 15 to 30% of people diagnosed with hypertension, meaning as many as 1 in 3 may be treated for a condition that only shows up in a doctor's office. Here's the measurement protocol I give every patient over 60. Sit quietly for 5 full minutes, feet flat on the floor, back supported, arm resting at heart level. No talking, no phone, no television. Take 2 readings 1 minute apart and record the lower one. Do this twice a day, once within 20 minutes of waking, before coffee, and once before bed. Alternate arms every other day. Do this for 7 consecutive days. 28 readings total. Then average them. That average, not a single office reading, is your true resting blood pressure. If it consistently runs above 150 systolic or 90 diastolic, that needs attention. If it falls between 130 and 149, bring those 28 numbers to your next appointment. They're worth far more than 1 reading taken in an exam room. Now, the question I probably get asked more than any other: when does high blood pressure become a genuine emergency, and when is it just a spike? Here's the part that surprises people. A high number by itself, even a very high one, isn't automatically an emergency. Say you check your pressure at home and see 170/95. The instinct is to panic. But that instinct is often wrong, because a single elevated reading can simply reflect stress, pain, caffeine, or anxiety about taking the reading in the first place. The real signal to watch for isn't the number alone. It's the number combined with symptoms. If your systolic pressure is above 180 or your diastolic is above 120, and you notice any of the following, call for emergency help immediately. A sudden, severe headache unlike any you've had before. Chest pain or tightness. New or worsening shortness of breath. Blurred or partially lost vision. Trouble speaking or sudden confusion. Or numbness or weakness on one side of your body. Together with those symptoms, this combination points to a hypertensive crisis. Pressure actively damaging organs in real time. Research on hypertensive crises has found mortality risk within the first year can run as high as 25% if it isn't treated promptly. But if your reading is 170 over 95 and you feel completely fine, no headache, no chest pain, no vision changes, that's not a crisis, it's an urgency. Sit down, rest for 5 minutes, breathe slowly, and take the reading again. In most cases, the number drops 15 to 25 points within 10 minutes. If it stays elevated after resting, call your doctor that day or the next morning rather than heading to the emergency room. I remember a patient, a retired school secretary in her late 60s, who called my office in a panic after her home monitor read 182 over $98. She was already putting her shoes on to drive to the ER. I asked 3 questions. Headache? No. Chest pain? No. Vision changes? No. I asked her to sit down, close her eyes, breathe slowly for 10 minutes, and check again. She called back 12 minutes later at 148 over 84. Still elevated, but no longer crisis range. The first reading had come right after a tense phone call with a family member. Adrenaline, not disease, had driven the spike. She didn't need the emergency room. She needed 10 minutes and a few deep breaths. The lesson is this: we treat patterns, not single spikes. One high reading is a data point. 2 weeks of consistently high readings is a pattern worth acting on. But know the line. Above 180 over 120 with any of those symptoms is not something to sit and monitor. That's a call for help situation, and minutes matter. Let's pull this together. Your blood pressure has 2 numbers: systolic, the force at each heartbeat, and diastolic, the pressure between beats. After 60, the top number usually matters more because of arterial stiffness, but a diastolic below 60 is a warning sign most people never hear about. For ages 60 to 75, aim for systolic below 130 at rest. Treat 140, 149 as a signal to monitor and adjust, and treat 150 or higher as too high. Past 75, below 140 is the general goal, and 150 or above is too high, regardless of age. A diastolic sustained at 90 or higher at any age needs attention. You now also know pulse pressure, the gap between your 2 numbers, with below 40 as normal and above 60 as a real warning of arterial stiffness. You know that a single high reading isn't a diagnosis, a consistent pattern is. You know the 5 common measurement errors that can distort a reading by 25 to 35 points, and the protocol that gives you a genuinely accurate baseline. 5 minutes of rest, proper positioning, 2 readings a minute apart, twice daily, for 7 days. Averaged. And you know the line between a spike to monitor and a crisis that needs emergency care. 180 over 120 with severe headache, chest pain, vision changes, or one-sided weakness. In more than 20 years of practice, the biggest problem I've seen isn't pressure that's too high. It's patients who don't understand their own numbers, who are anxious about readings they can't interpret, who end up over-medicated from a rushed office reading, or under-medicated because their true pressure was never properly measured. Understanding these numbers isn't meant to frighten you. It's meant to hand you back some control. So take your reading tonight, using the protocol above, and calculate your pulse pressure. If this helped, consider subscribing, and share it with someone over 60 who worries about their numbers. It might give them the same clarity it's given you. Blood pressure isn't a mystery, and it isn't a verdict. It's a signal, and now you know how to read it. This video is for educational purposes only and does not constitute medical advice. Consult your physician before making any changes to your medications or health routine.